The blood pressure pill sitting in your medicine cabinet right now has about a 50% chance of not working the way your doctor thinks it does. Not because you forgot to take it, not because you are eating too much salt, but because that pill was developed and tested primarily on white bodies, and your black body responds to it in a fundamentally different way. I am Dr. Marcus Webb. Today, I want to walk you through the science behind one of the most significant and least discussed gaps in American medicine. This is not about fear. This is not about blame. This is about understanding your own body so you can have a better conversation with your doctor and take real control of your health. Let me start with the number that stopped me when I first read it in the research. A class of blood pressure medications called angiotensin-converting enzyme inhibitors, which most doctors call ACE inhibitors, reduces the risk of heart attack and stroke in white patients by roughly 40%. In black patients, that same class of medications reduces that risk by closer to 20%. Some studies show the gap is even wider than that. That is not a rounding error. That is half the protection from the same pill. And if your doctor prescribed you one of those medications without telling you this, it is not because they were hiding something from you. It is because the clinical trials that produce those numbers did not include enough black patients to make this difference visible until the data was looked at much more carefully, years later. So let's talk about what is actually happening inside your body. Your body has an internal system that controls blood pressure. It is called the renin-angiotensin-aldosterone system. That name is a mouthful, so think of it this way. Your kidneys work like a pressure sensor. When they detect that your blood pressure is dropping too low, they release a protein called renin. Renin kicks off a chain reaction inside your body. That chain eventually produces a chemical called angiotensin II, which squeezes your blood vessels tighter and pushes your blood pressure back up. ACE inhibitors work by blocking a critical step in that chain. They prevent angiotensin II from forming in the first place. Here's the issue. Researchers have found consistently across multiple studies that Black Americans, as a population, tend to have lower renin activity in their blood. That means the chain reaction that ACE inhibitors are designed to interrupt is already running at a lower level in many black bodies. If you give someone a drug that blocks a chain that was already moving slowly, you are not going to see the same dramatic result you would get in a patient whose chain was running at full speed. The drug is doing what it was designed to do, but the target it was designed to hit is simply not as active in black patients on average. And this is not a personal failing. It is not about lifestyle choices. This is biology that has been measured and documented in peer-reviewed research for decades. It reflects patterns in how different populations regulate certain internal systems, shaped in part by genetic variation and ancestral adaptation. There is a second layer to this story that matters just as much. Black Americans tend to have higher rates of what researchers call salt-sensitive hypertension compared to other populations. Salt sensitivity means the kidneys hold on to sodium more aggressively than what we see on average. When your body holds on to sodium, it pulls water along with it. More fluid in your bloodstream means more pressure pressing against the walls of your arteries. That is high blood pressure, explained as simply as I can explain it. And because this is a sodium-driven form of hypertension rather than a renin-driven form, medications that specifically target the renin chain are going to be far less effective at fixing the root problem. Now here is where the data gets undeniable. In 2002, results were released from one of the largest blood pressure trials ever run in the United States. It was called the Antihypertensive and Lipid-Lowering Treatment to Prevent Heart Attack trial. Researchers enrolled over 33,000 patients across more than 600 sites. And when they broke the results down by race, something very clear emerged. In black patients specifically, a class of medications called thiazide diuretics outperformed ACE inhibitors in preventing heart failure and stroke. Thiazide diuretics work by helping your kidneys flush out excess sodium and water. That is exactly the mechanism that addresses the salt-sensitive biology that is more common in Black patients. Not blocking the renin chain, removing the sodium that is driving the pressure up in the first place. Let me say that in plain language one more time. The largest hypertension trial in American history showed that Black patients do better on a different class of medication. And the reason is rooted directly in the biological differences we have been discussing. Today, the guidelines from the American Heart Association and from the International Society of Hypertension both reflect this finding. They recommend that Black patients with high blood pressure be started on either a thiazide diuretic or a calcium channel blocker as the first choice of treatment. A calcium channel blocker works by relaxing the walls of your blood vessels directly. It does not rely on the renin chain at all. That is why it tends to work effectively regardless of a patient's renin levels. Both of these drug classes have strong evidence supporting their use in Black patients. And yet, study after study continues to show that Black patients are still being prescribed ACE inhibitors as their first-line treatment at higher rates than the guidelines recommend. Here is what I need you to hear right now. We have known about these differences for decades. The data has been published. The guidelines have been updated. And still, the gap persists between what the science says and what Black patients are actually receiving. The consequences of that gap are measured in strokes that could have been prevented, kidney disease that progressed further than it had to, heart failure that arrived years earlier than it should have. If that makes you feel something right now, that is the right response. That feeling is why this channel exists. And if what you just heard is the first time you have ever learned that your medication may be treating a version of high blood pressure that does not match your biology, I want you to do something for me. Share this video with someone you love who is managing blood pressure. A parent, a sibling, a neighbor from church. This is the conversation they deserve to have with the people they trust most. If this channel is giving you information that closes the gap between what medicine knows and what our community has been told, please like this video and subscribe to Marcus Webb, Black Health Truth. And drop a comment below telling me what blood pressure medication you were prescribed first, and whether your doctor ever explained why that specific medication was chosen for you. I read every comment. Your answers matter to me, and they shape what I cover next. Now let me give you concrete steps you can take right now. Step 1. Do not change or stop any medication you are currently taking without talking to your doctor first. I want to be absolutely clear about that. What I want you to do is go to your next appointment prepared with a specific question. Ask your doctor whether your medication was selected with your specific biology in mind. Ask whether a calcium channel blocker or a thiazide diuretic would be appropriate for you based on your current lab values. Your doctor may have excellent reasons for the choice that was made, but you have every right to understand what those reasons are. Step 2. Ask about a plasma renin activity test. This is a blood test that measures how active your renin-angiotensin-aldosterone system actually is in your body right now. If your renin activity is low, that is direct data suggesting that ACE inhibitors may not be the most effective first choice for your individual biology. This test exists. It is available. Ask your doctor whether it makes sense for your situation. Step 3. Take sodium seriously for the right reasons. I know you have heard the advice to cut back on salt, but the reason it matters specifically for Black patients dealing with salt-sensitive hypertension is not just general wellness advice. It is targeted intervention based on how your kidneys are working. Research shows that reducing sodium can lower blood pressure by 8 to 10 points in people with salt-sensitive hypertension. That is clinically meaningful. Combined with the right medication, that change can make a real difference in protecting your heart and kidneys. Step 4. Track your blood pressure at home and bring that record to your appointments. High blood pressure causes no pain. It gives you no clear warning before it damages your heart, your kidneys, or your brain. A home blood pressure monitor is inexpensive. A notebook to write your readings down costs almost nothing. But the pattern you document over weeks and months tells your doctor something that a single reading in the office never can. Step 5. If your blood pressure is not responding to your current medication after a few months of consistent use, say that directly to your doctor. The guidelines give physicians multiple options. Your job is to make sure those options are being fully considered for you. I want to close this with something real. I became a doctor because I grew up watching people in my community live with conditions that were manageable but never managed well. I watched family members take their blood pressure pills faithfully every single day and still end up with heart disease and kidney damage before they should have. I did not understand what I was seeing then, but I understand it now. Some of those people may have been prescribed a medication that was less likely to work for their biology, and no one ever told them there was another option. That is not a story I can accept. And it is not a story you have to accept either. This content is for educational purposes only and does not replace the guidance of your physician. Please talk with your doctor before making any changes to your treatment plan. But go into that conversation knowing what the research says about your body, because you have always deserved that information. I am just making sure you finally have it. This is Dr. Marcus Webb, and this is Black Health Truth.